Thank you for the introduction and thank you for giving me the opportunity to present at this Congress. My disclosure. So hepatitis B vaccine, first generation of hepatitis B vaccine for humans was used in 1981. Now HBV vaccine is prepared with biosynthetic surface antigen made using recombinant technology. The vaccine is safe and is well tolerated, and in HIV-infected patients, no significant adverse clinical reactions to HBV vaccination was distinct for HIV non-infected patients. Vaccination programs against HBV has succeeded in reducing HBV endemicity and the incidence of hepatocellular carcinoma in children. So now HBV vaccine is included in the expanded program on immunization since 1995. What about vaccine schedule? Standard vaccine schedule includes 3 doses given intramuscularly in the deltoid at 0, 1, and 6 months. In healthy persons, about 90 to 95% of vaccinated young adults achieve seroprotection with hepatitis B surface antibody more than 10 milliunits per ml, 1 to 6 months after the last injection. When anti-HBs is less than 10 milliunits per ml, we classify these patients as non-responders. And for patients with anti-HBs more than 100 milliunits per ml as high responders. The duration of anti-HBs persistence is not known precisely, but we think that we know that in 91% of healthy adolescents have persistence of anti-HBs antibodies. But current opinion suggests that immunity may be lifelong. The factors reducing HBV vaccine response are well known. They are age more than 40 years, male gender, obesity, smoking, HLA, and immunodeficiency such as hemodialysis, cirrhosis, and of course HIV infection. What do you know? What do we know about vaccination against HBV in HIV-infected patients? In HIV-infected patients, response rates are reduced. Reduction is between 23 and 65%, depending on the period of the studies, with a standard HBV vaccine schedule versus more than 90% in healthy adults. The percentage of response is correlated with CD4 cell count, but also with plasma HIV viral load. We know also that in responders individuals, we are, when they are HIV infected, lower anti-HBs antibodies levels, and the durability of the response is reduced compared to healthy individuals. In this study, which was a meta-analysis and systematic review about persistence of vaccine response in HIV-infected patients, the percentage of adult HIV-infected patients seroprotected after 2 years was only 38%, and after 5 years, only 17% of the HIV-infected patients were protected. Several strategies have been proposed to improve the HBV vaccine response in HIV-infected patients. Among them, higher dose of vaccine antigen and/or increase of vaccine doses, it has been proposed to revaccine the non-responders patients, the use of cytokines or adjuvants in combination with vaccination, but also intradermal vaccination. In this study, which was conducted with ANRS in France, we explored the safety and immunogenicity of 4 intramuscular double dose of vaccine and 4 intradermic low dose of HBV vaccine versus standard hepatitis B vaccine regimen in adults with HIV infection. This was a randomized control trial conducted in 437 HIV-infected patients with CD4 cell count more than 200 per millimeter cube. And as you know, in this figure here, the percentage of responder was 65% in the IM20 schedule, which is the standard schedule, but the 2 alternative regimen was higher, with 82% of responders with the 4 double dose regimen and 77% in the intradermal regimen. We looked also to the percentage of high responders with in this trial a higher percentage of high responder in the IM40 group, which is showing is here, and also a higher GMT antibodies for the 4 double dose regimen. In this study, there was no safety signal and no difference in the impact of CD4 cell count or HIV RNA, depending of the group. In this study, we were able to look on predictive factors for response at week 28, and we show that the alternative vaccine regimens was a predictive factor with a higher response in the 2 alternative regimen. We show that female sex, lower age, and not active smoking were also factors for better response. And concerning HIV factors, higher baseline CD4 cell count and undetectable plasma viral load was associated with better response to hepatitis B vaccination. Another strategy to improve the hepatitis B vaccine response in HIV-infected patients is the use of adjuvant. In this study, the adjuvant was CpG 7909. In this study, the patient received 3 injections of hepatitis B vaccine at double dose at 0, 1, and 2 months, associated or not with the adjuvant. And the anti-HBs titers was measured at 6 months intervals for up to 60 months. The results show that a higher proportion of participants achieving and retaining seroprotection in the adjuvant arm compared to the non-adjuvanted. The second question is vaccination in HBV vaccine non-responding HIV patients. And I'm going to show here the results of the ANRS HB04 study. The objective of the study was to compare the immunogenicity of 2 strategies of revaccination in HIV-1 infected patients who didn't respond to previous hepatitis B vaccination. To be included in the study, the patient have to have a CD4 cell count more than 200 per millimeter cube, a history of at least 2 injections of hepatitis B vaccine and no more 4 injections in the past. No history of vaccination with double dose of vaccine, and they have to be revaccinated with 1 dose of hepatitis B vaccine and to have no response after this revaccination. They were randomized to receive 3 sample doses of vaccine or 3 double doses of vaccine, of hepatitis B vaccine, and the results are presented here and show that the double dose revaccination did not achieve a higher response rate in comparison to a single dose regimen, but provide, as it's shown here, higher anti-HBs titer with longer sustainability, and these results are in press in Lancet Infectious Disease. Another question for vaccination against hepatitis B in HIV-infected patients is the question about patients with isolated anti-HBC antibodies. Isolated anti-HBC serology pattern is observed in about 15 to 20% of HIV-infected patients, but up to 40% in HIV-HCV co-infected. This pattern has been linked to a risk of HBV reactivation or reinfection, and this serology pattern may represent either chronic hepatitis B in presence of mutant that prevent the detection of HBs antigen, but also an occult HBV infection with detectable HBV DNA, and it may be also a transition from the profile of natural immunity with undetected anti-HBs antibodies. What is the anamnestic response after vaccination of HBV vaccine, after 1 dose of HBV vaccine of this patient with isolated anti-HBC antibodies? Depending on the studies, between 32 and 46% of the patients are able to mount anti-HBs antibodies. Among patients without anamnestic response to 1 dose of hepatitis vaccine, the response rate after vaccine regimen is 74% after 3 to 6 simple vaccine doses, but among 40% after only 3 doses, which is the results of this study published in Clinical Infectious Disease, and in a more recent study conducted also in France, we show that 89% of patients were responders after 3 double doses of HBV vaccination. So to conclude, we can say that all HIV-infected patients should be screened for HBV markers, as we have seen before that in this situation of HIV infection, the percentage of chronic infection is higher than in healthy individuals. Vaccination against HBV is recommended in all non-immune HIV-infected patients, and it is preferable to wait an HIV plasma virus undetectable before vaccination, and if possible, to wait for a CD4 cell count more than 200 per millimeter cube. Based on available data, we conclude that 4 EM double dose regimen at 0, 1, 2, and 6 months is recommended for naive patients, in particular for patients who are male and smoking, and for low CD4 cell count. For non-responders patients, we can recommend 3 double dose regimens at 0, 1, and 6 months. it is important to test anti-HBs antibodies 1 to 2 months after the last injection to detect the non-responder patients, and following successful immunization, anti-HBs antibodies level should be measured annually, and a booster dose should be offered to patients with antibodies below 10 milliunits per milliliter. And thank you for your attention.